All right. So, and can everyone see my slides?
Yep, we're good on the slides.
Perfect. So first I want to thank the coordinators of the this Empire lecture series and also the New York section for inviting me to give this presentation. This is a presentation that's really geared towards residents and medical students, as these are, I'm talking about really a lot of physiology and pathophysiology about Micturition. So my talk is titled Neural Pathways of Micturition. I have no disclosures. And so, you know, talking about neural pathways and neurourology, why is it so important to learn? So number one, you know, the central nervous system disorders, they're a frequent cause of voiding dysfunction. Two, timely management of these voiding dysfunctions can avoid irreversible adverse outcomes. But more importantly, for the residents and trainees, these are very common test questions for the in-service, the written boards, and the oral boards. So here's a brief outline of my talk today. We're going to talk about the normal lower urinary tract physiology. We'll talk about briefly evaluation of neurourologic disorders. We'll talk about the categorization of disorders by level of neurologic lesion. And then we'll briefly also talk about treatment options. All right, so to talk about the normal physiology first. So the bladder itself has two basic physiologic functions. So if you think about it in your head as two basically buckets of function, one is storage. So it needs to provide a low pressure storage that provides adequate volume with normal sensation. And the second function is voiding. And so you want the bladder to be able to provide periodic voluntary voiding that's performed in a coordinated and a complete fashion. So what's involved in Micturition? Well, the anatomy involved is obviously the bladder, but also the bladder neck, the external urethral sphincter, and the urethra. And then as far as the neural pathways involved, it involves the peripheral nervous system, which includes the autonomic system. So both the parasympathetic and sympathetic systems, as well as the somatic system, where you have the afferents giving sensory information and the efferents giving motor control. So let's break that down even further. If you think about the parasympathetic pathways are used to excite the bladder or contract the bladder and to relax the urethral smooth muscle. So if you think about it, parasympathetics are used for voiding. The sympathetics are used to inhibit the bladder body. So that's to prevent contractions of the bladder and to excite the bladder base and urethra to close the outlet. So that's more important in your storage function. And then the somatic systems are used to excite the external urethral sphincter and to provide sensory input from the bladder. So we're going to go even deeper down into this because this information, although it seems very, very detailed, are questions that can come up on your in-service exam and the written boards. So let's take a look at the parasympathetic pathways. And if you remember from medical school, you had preganglionic neurons and postganglionic neurons. So let's talk about where they're located and how they travel. So if you look at the preganglionic neurons of the parasympathetic system, they're located in the lateral part of the sacral parasympathetic nucleus of the spinal cord. So what you need to remember there is that's S2 to S4. So the sacral nerve roots at S2 to S4 is where you'll find the preganglionic neurons. The axons of those preganglionic neurons will then travel through the ventral roots to peripheral ganglionic cells. And then that's where they'll innervate postganglionic neurons, which are generally located in the detrusor wall itself, so in the target organ or in the pelvic plexus. And what they do is initiate bladder contraction, like I mentioned earlier. So this is showing this in more of a schematic form if people prefer pictures. If you look at the parasympathetic system, the yellow here are the preganglionic fiber, the axons coming through. This yellow blob here is representing the pelvic plexus, where they end here, and then some also end at the bladder. And the green little ones are the postganglionic axons. Another detail that could definitely be asked on exam questions are neurotransmitters and receptors. So if you also recall back from medical school, the neurotransmitters of the parasympathetic system is acetylcholine, both at the ganglion level and at the bladder level. For the receptors, there are two different types of receptors in the parasympathetic pathway. So at the ganglion, which would be at your pelvic plexus or in the bladder wall, those would be nicotinic receptors. And then at the postganglionic target, it would be a muscarinic receptor in the bladder wall itself, which causes detrusor muscle contraction. So now we're going to switch gears to the sympathetic pathway. Again, there's going to be preganglionic neurons and postganglionic neurons. The preganglionic neurons of the sympathetic pathway are located in the thoracolumbar region of the spinal cord. So you need to remember T11 to L2. Those axons of the preganglionic neurons will then travel through the sympathetic chain, and then they'll target the postganglionic neurons, which are located in the inferior mesenteric ganglion or in the pelvic plexus. Then those postganglionic axons will then travel through hypogastric nerves to the effector organs. So that in this image here looks like the red lines are the preganglionic sympathetic fibers running through the sympathetic chain, running down. This right here is the inferior mesenteric ganglion, which is one target, and then the pelvic plexus is another target. And then the blue fibers here are representing the postganglionic sympathetic fibers targeting the bladder and the bladder base. As far as the neurotransmitters for the sympathetic pathway, you have both acetylcholine, which is at the ganglion, and then norepinephrine, which is at the bladder. As far as the receptors, again, you have nicotinic receptors in the sympathetic ganglion. And then at the target organ, you have both alpha receptors that are located at the bladder base and bladder neck, which will lead to closure of the outlet. And then beta receptors, which are in the bladder body, which lead to detrusor muscle relaxation. And those two are important receptors as they're both targeted by pharmacologic agents. Now to talk about the somatic pathway. The somatic pathway involves your motor neurons, the efferent pathway. Those motor neurons are located in the ventral horn, otherwise known as the Onuf's nucleus. So that will sometimes come up on test questions as well. And that'll be located in S3 and S4. Those neurons will travel through the pudendal nerve and innervate the external sphincter muscle. In your sensory pathway or afferent pathway, you'll have neurons that travel via the pelvic, hypogastric, and pudendal nerves to the dorsal root ganglia of the lumbosacral spinal cord. Those neurons will monitor bladder volume and amplitude of bladder contraction via both myelinated, which would be A delta, and unmyelinated C fibers within the bladder wall. And so again, in this picture, the somatics here, the sensory is this sort of lighter blue that's coming from the sphincter muscle, as well as the motor neuron here is the red coming from the sphincter muscle, or going to the sphincter muscle, sorry. So let's talk about the actual function of bladder filling and voiding. Filling and voiding, the two main functions I mentioned earlier that the bladder performs, is organized as on and off switching circuits. And so there's a reciprocal relationship between the bladder and the outlet. So to be able to void, the bladder needs to do one thing and the outlet needs to do another, and then it's the reverse for storage. So let's talk about storage, and when I said these on-off circuits, those are predominantly these reflex arcs. And so there's a storage reflex, or otherwise known as a guarding reflex arc that's used during storage. It's really activated during bladder filling, and then it's organized primarily by the spinal cord. So this is not voluntary. And then there's an involuntary increase in external sphincter activity during bladder filling to help close the outlet. So the reflex itself starts with bladder filling, and there's afferent firing from the bladder to say that the bladder is filling or full. Then there's that goes to the spinal cord, and that then leads to sympathetic outflow to excite both the bladder neck and the urethra. And then sympathetic outflow here showing where it's inhibiting the detrusor muscle from contracting. And then also there's a reflex that goes to the pudendal motor neuron to excite the external sphincter muscle to help it contract as well. Now there's a reflex also for voiding. That's organized in the brain as opposed to predominantly in the spinal cord. And that's because it's under voluntary control. It's mediated by the spinal bulbospinal pathway that passes through the pontine micturition center, which is shown here in blue. So that's the blue arrows are the spinal bulbospinal pathway. And so what does that reflex look like? You have bladder distension, which again causes afferent activity that passes through the spinal cord and then up to the brain to the periaqueductal gray matter. That then activates the spinal bundle pathway through the pontine micturition center. What that does then leads to inhibition of the sympathetic outflow and pudendal outflow to the urethra. That's shown in red here. And then it'll stimulate the parasympathetic outflow to the bladder, which is shown here in this green, and to the internal sphincter smooth muscle to allow for voiding. So now that that's a pretty quick overview of the normal physiology of the lower urinary tract, if you actually saw a patient come into your clinic with voiding dysfunction or voiding complaints and a neurologic condition, how would you evaluate them? And so for the residents out there, always remember when you're evaluating a patient, especially for the oral boards, you want to perform a complete history and physical first. And so what does your history entail? In your history, you're going to want to elicit the patient's voiding symptoms, the onset and duration of those symptoms, especially in relation to their neurologic event. You want to ask them, voiding symptoms such as, first storage symptoms, such as frequency, urgency, nocturia, and urinary incontinence symptoms, as well as asking about voiding symptoms, which are more obstructive symptoms like urinary hesitancy, Valsalva voiding, or urinary intermittency. You'll also want to get a past medical history, past surgical history for women, and OBGYN history, and then also get any further neurologic history from the patient. As far as the physical exam, you want to do a complete general exam. Specifically, you'd want to look at the patient's back and spine and see if there's any sacral dimpling or hair tuft. That might be an indication that they have spina bifida. In men, you'll want to include a DRE and a prostate exam to assess their prostate size. In women, you'll want to perform a pelvic exam. And you'll also want to perform a basic neuro exam specific to these neural pathways. You'll want to do sensory testing of the genitalia, and that'll give you information about the sensory somatics if they're still intact. You can do a basic motor testing to look at lower extremity strength. You'll want to do a rectal exam for anal sphincter tone. And you may also want to examine some of the neuromuscular reflexes that are specific to some of the sacral roots. So that would be like a bulbocavernosus reflex, where you would squeeze either the head of the penis at the glands or the clitoris of a woman, and that would cause an anal sphincter contraction. An anal reflex, which would be stroking the skin around the anus or the perineum and looking again for an anal sphincter contraction. Or cremasteric reflex, where you would, in men, where you would stroke the inner thigh and look for the ipsilateral testicle to pull up. As far as diagnostics, a urinalysis would be recommended, especially in patients that may have some irritative voiding symptoms, and you'd want to rule out any infectious etiology. Blood work, a basic metabolic panel is usually recommended, especially, particularly, checking renal function, so a creatinine and a GFR. A bladder scan to assess post-void residual, again, if patients are describing especially obstructive voiding symptoms. A non-invasive uroflow, again, if patients are describing a lot of obstructive urinary symptoms. And as far as imaging, a renal ultrasound is probably a good place to start for most neurogenic bladder patients to assess their upper tract. That being said, if something's picked up on that, say you see large kidney stones, you may then need to follow that up with a CT stone protocol to further assess those. If you saw hydronephrosis in the absence of any stones, you may need a CT urogram to assess that, or even a VCUG to look for reflux. And then if you saw a lot of scarring or atrophy of the kidney, you may consider nuclear renal scans to look at the split function of the kidney. Urodynamics can be considered in patients as well, especially neurogenic patients where you may have suspicion of any impaired bladder compliance. And cystoscopy is generally not recommended these days on a routine basis for neurogenic bladder patients, but is recommend, of course you would follow recommendations if the patient had any history of hematuria, either gross or microscopic hematuria. So let's talk about now the characterization of voiding symptoms by the level of the lesion. And the reason I broke it up this way is because there are very characteristic symptom patterns and urodynamic findings that are dependent on the level or location of the lesion. And so generally speaking, we're talking about above the pontine micturition center, and then between the brainstem and the sacrum, and then below the sacrum. So let's break that down even further. So lesions above the brainstem or suprapontine lesions, how I have organized this is to split it up into what the detrusor muscle does, how the sphincter muscle behaves, and then whether sensation is intact or not. And so this is the pattern that you would see in a suprapontine lesion. The detrusor muscle will be overactive. The sphincter muscle would be coordinated. So we're talking about both the striated muscle and the smooth muscle will be coordinated, and sensation will be intact. So the bottom line is these patients will have detrusor overactivity with complete emptying because their sphincter muscles are coordinated. What does that actually look like? What would the patient complain of? They'll complain of overactive bladder symptoms such as frequency, urgency, nocturia, even urge urinary incontinence. And examples of neurologic examples of these are, a CVA, traumatic brain injury, brain tumors, cerebral palsy, Parkinson's disease, and dementia. Multi-system atrophy is also considered a suprapontine lesion, but remember, again, this is a testable question. In multi-system atrophy, they'll have an open bladder neck. So the smooth sphincter will be open at rest. Now I'm going to break up the suprasacral spinal cord lesions between the brainstem and T6 and then T6 to S2. So if we look at brainstem to T6 lesions, the detrusor muscle again will be overactive. The sphincter muscle will be discoordinated, so they'll have DSD. Both the striated sphincter muscle and the smooth sphincter muscle will be dysenergic. And then their sensation will be absent. So the bottom line here is they'll have detrusor overactivity with DSD and incomplete bladder emptying with a functional obstruction because of the DSD. What does that look like? What would the patient complain of? They'll complain of overactive symptoms like frequency, urgency, nocturia, and urge incontinence, but they'll also have this functional obstruction from their DSD with incomplete emptying and possibly even high detrusor pressures while voiding or while trying to void. These patients also above T6 will have autonomic dysreflexia responses to stimuli below the level of injury. And so examples of these type of lesions would be spinal cord injuries, spinal tumors, spinal cord infarctions, disc disease, spinal stenosis, and also multiple sclerosis. So I'm going to do a little sidebar here about autonomic dysreflexia. That is an acute, massive, disordered autonomic response to specific stimuli in patients with spinal cord injuries above T6. They could be stimuli, a lot of common stimuli for autonomic dysreflexia are actually GU stimuli, such as a bladder overdistension or a full bladder or a UTI. Could also happen from fecal impaction and constipation, pressure sores. It could be even something that seems so minor, like an ingrown toenail can cause autonomic dysreflexia. And what does the patient feel when they have it, when they experience it? They get a pounding headache, severe hypertension, and they'll have flushing and diaphoresis above the level of their lesion, as well as bradycardia. And what do you do if you see a patient that's experiencing autonomic dysreflexia? You want to reverse whatever that stimuli is. So for example, if their bladder is very full and overdistended, you're going to want to catheterize them immediately and empty their bladder. If they're fecally impacted, you're going to want to disimpact them. If they have, something, a belt too tight on them, you're going to want to loosen that up. All right, so back to the level of lesions now. So now we're going to look at T6 to S2 lesions. This looks similar to the ones above T6, but I've highlighted one very specific difference. They will have the detrusor muscle overactivity. They will have DSD, but their smooth sphincter will be coordinated. So they'll really only have striated sphincter dyssynergia. And again, their sensation will be absent. They're again going to look very similar to the other patients that were above T6, again with overactive bladder symptoms and functional obstruction. And also the examples are the same. Now below S2, you'll have a pattern where the detrusor muscle will now be areflexic, and the sphincter muscle will be competent, but it would be fixed and non-relaxing. So the striate sphincter will be fixed and the smooth muscle sphincter will be open. And again, they'll have absent sensation. So what does this look like? This is going to look like a patient that has urinary retention and also may have stress urinary incontinence because their striated sphincter muscle cannot contract as a guarding reflex because it's fixed. Examples of these would be cauda equina syndrome, radical pelvic surgery such as an APR or radical hysterectomy or proctocolectomy, mostly because of disruption of the pelvic plexus, and as well as trauma, which could also disrupt the pelvic plexus. As far as spinal cord injuries, there is something called spinal shock. And so that'll happen acutely after a spinal cord injury at any level. And what that looks like initially is an acontractile detrusor muscle. They'll have a closed urethra and sphincter, and they'll have loss of sensation. And so what they'll look like is they'll have urinary retention, but be continent because of their closed urethra and sphincter. This could last days to months, and generally speaking, I advise my patients it could be anywhere from 6 to 12 weeks. Now, if their spinal cord injury is above S2, after the period of spinal shock, then they'll convert over to the pattern that I had described previously, where they'll have detrusor overactivity symptoms and possibly DSD as well. So now that you know all the different pathophysiology of neurogenic bladders, let's talk about treatments. So the goals of treatment when you're seeing a patient with suspected neurogenic bladder is to protect their upper tract function. You want to minimize complications such as infections and stones. You want to provide an acceptable and reasonable means of draining their bladder, and you want to help to maintain urinary continence. So I'm going to break up the treatment options between the two different functions of the bladder, meaning storage and voiding. And so for treatments for failure to store, you could have a failure to store because of detrusor overactivity or an impaired compliance. And those options include behavioral modifications. So always remember when you're test taking, the first line option is always, a conservative treatment. So that would be behavioral modifications like time voiding, pelvic floor exercises. External collecting devices could be used, such as for men, like a condom catheter. Medications for detrusor overactivity, like the anticholinergics and beta-3 agonists that are on the market. Botox injections. So now we're talking about third line therapies for overactive bladder, like Botox injections, PTNS, and sacral neuromodulation. And then the last line would be, you could offer someone an augmentation cystoplasty. Now, if the patient's failure to store is due to an outlet deficiency, again, behavioral modifications such as pelvic floor exercises, time voiding, again, external collection devices, specifically for men, like a condom catheter. And then here, this is where the treatment options diverge from the previous one, where you could offer patients urethral bulking agents for their outlet, or sling procedures, artificial urinary sphincters. You could offer someone a bladder neck closure, and that's especially a good option to use for patients who have devastated urethras due to urethral erosion from chronic catheterization in women. And then lastly would be a urinary diversion. Now, if we look at treatments for failure to empty, if the failure to empty is due to detrusor areflexia, of course, there's catheterization. So you can offer patients intermittent catheterization, as well as or chronic indwelling catheter. And you could either offer an indwelling urethral Foley catheter versus a suprapubic tube. My personal preference in women is to offer them all suprapubic tubes because of the risk of urethral erosion in women with a chronic indwelling urethral catheter. This may be more applicable to women who have shorter urethras and less urethral resistance. They could still void, but use Crede and Valsalva maneuvers to empty their bladder. Sacral neuromodulation does have an indication for non-obstructive urinary retention, albeit the success rates are not as good as the success rates seen with overactive bladder, and with success rates usually around 50%. And then urinary diversion. If the failure to empty is due to DSD, then again, you can offer catheterizations like I mentioned earlier. External sphincterotomy, that would be more applicable in men, where an external sphincterotomy could be done in combination with an external collecting device like a condom catheter. Other options are Botox injections that are injected directly into the external sphincter muscle as opposed to into the detrusor muscle itself. And then again, urinary diversion. So wrapping all this up, I could make some, you can conclude different things, but what the residents really want to know in conclusion is, what do I really need to study? What do I need to learn? So I've outlined 5 things that I think that it's really important for you guys to study and be sure that you are well-versed in going into your exams. One is that you should know the autonomic innervation of the lower urinary tract. And I also included that you should know the neurotransmitters and the receptor types, because those are testable questions. You should know the neural pathways for the guarding reflex and voiding reflex, because that may be asked. You'll want to know the characteristic symptom patterns and UDS findings based on level of lesion, like I outlined earlier. You'll want to know how to recognize autonomic dysreflexia and how to treat that. And you'll also want to know how to treat common neurourologic disorders. So that was a quick review.